Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the October 2024 issue of Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. We'll start with the asthma content area. Childhood asthma has the potential to impact adult life. In this issue, Savrin and colleagues explore data from a 60-year follow-up study of adults with a history of severe childhood asthma to identify potential differences in characteristics between individuals with persistent asthma and those with asthma remission in adulthood, defined as no use of asthma medication or asthma symptoms in the prior 12 months. 90% of 232 participants had current asthma, of whom 26% had an exacerbation in the past year. Participants with persistent asthma showed higher total IgE levels, lower FEV1 percent predicted, and a lower FEV1 to FVC ratio, also a higher fractional exhaled nitric oxide level and blood eosinophil count. These findings reveal persistence of asthma into adulthood of 90% of individuals with a history of severe childhood asthma, with persistence associated with lower lung function and higher levels of type 2 inflammatory biomarkers. Next is our chest infections content area. There's limited evidence about the most effective diagnostic approaches, management strategies, and long-term outcomes for community-acquired pneumonia in patients who have undergone solid organ transplantation. In this issue, Joeen and colleagues report findings from a retrospective analysis of solid organ transplant recipients hospitalized with community-acquired pneumonia, designed to assess the acute and long-term morbidity and mortality after community-acquired pneumonia in this population. 403 hospitalizations of 333 solid organ transplant recipients were included. More than one half of the patients required oxygen supplementation after admission. In-hospital mortality was 13.2%, and one-year mortality was 24.6%. High rates of acute cardiovascular events were also noted. Early blood cultures and bronchoscopy in the first 24 hours increased the odds of establishing an etiology. These findings highlight the high morbidity associated with community-acquired pneumonia after organ transplantation and the need for evidence-based guidance to improve outcomes. Also in this section is an original research article that reports outcomes of SARS-CoV-2 infection in individuals with chronic lung disease during both Delta and Omicron phases, and a research letter that assessed whether pneumocystis pneumonia presentation and treatment should be evaluated according to the underlying disease. Our COPD content area is next. Small airway obstruction has been associated with respiratory symptoms, cardiometabolic disease, and progression to COPD. The association of small airway obstruction with mortality is not known. In this issue, Santofimio and colleagues report findings from an analysis of over 250,000 adults with good quality spirometry measurements in the UK Biobank, designed to determine if spirometry-defined small airway obstruction is associated with increased mortality. Nearly 60,000 participants with small airway obstruction were identified, of whom 24,000 had isolated small airway obstruction. Those with small airway obstruction had increased all-cause, cardiovascular, respiratory, and neoplasm-related mortality risk. In those who never smoked, only respiratory and cardiovascular mortality risk was associated with small airway obstruction. These findings suggest that individuals with small airway obstruction have an increased risk of all-cause and disease-specific mortality, whether as a marker of underlying disease or in a causal role. Completing this section is a special features article that's a meeting report and literature review of the interplay of cognition and physical performance in COPD and interstitial lung disease. Next is our critical care content area. Sedative use may lead to delirium among patients in the intensive care unit. In this issue, Huespe and colleagues report findings from a randomized controlled trial of 99 patients admitted to a tertiary mixed ICU that compared clinical assessment to processed EEG monitoring, or BIS monitoring, guidance of sedation, designed to determine if BIS-guided deep sedation can reduce sedative dose and increase delirium-free and coma-free days. There was no significant difference in delirium-free and coma-free days between the groups, but propofol doses were significantly lower in the BIS monitoring group. An increase in delirium and coma-free days was noted in the subgroup of patients sedated for greater than 24 hours. These findings suggest that BIS monitoring may reduce sedative drug use and could improve delirium and coma-free days in those requiring sedation for more than 24 hours. Other original research in this section includes an evaluation of intensive care unit staffing in the United States, an assessment of the differential effect of PEEP strategies in ARDS patients based on clinical subphenotype, and a cohort study that explored the association of pregnancy with outcomes among critically ill reproductive-aged women. Onto our diffuse lung disease content area. Microscopy is the gold standard to differentiate BAL fluid leukocytes, but local expertise is often unavailable in clinical practice. In this issue, Bratke and colleagues report an evaluation of 745 BAL fluid samples, 455 of which were from patients with interstitial lung diseases, with a new automated flow cytometric method for BAL fluid leukocyte differentiation to determine if automated flow cytometry can be used instead of microscopy to differentiate BAL fluid leukocytes. They found a strong correlation between flow cytometric and microscopic results in all leukocyte subpopulations, with mean differences between the methods of less than 2% for all cell types and less than 20% in more than 95% of all samples. Results were independent of total leukocyte counts. These findings suggest an automated flow cytometric method for BAL fluid leukocyte differentiation provides similar results to microscopic analysis, which can be useful in settings where local expertise is unavailable. Also in this section is a systematic review and meta-analysis of pulmonary hypertension in interstitial lung disease, and completing the section is a chest review of diseases involving the lung peribronchovascular region, presented with a CT pathologic classification. Onto our education and clinical practice content area. There's currently no minimally invasive method to monitor diaphragm hemodynamics. In this issue, Bird and colleagues evaluated quantitative contrast-enhanced ultrasound of the costal diaphragm as a means to measure relative diaphragm blood flow in 16 healthy participants during both unloaded breathing and 3 stages of loaded breathing. Relative diaphragm blood flow increased with each stage of loading from 3.1 acoustic units per second during unloaded breathing to 13.5 acoustic units per second at maximum loading. The relationship between diaphragmatic flow and pressure was reproducible from day to day. Relative blood flow had good to excellent retest reliability and excellent interanalyzer reproducibility. These results suggest that contrast-enhanced ultrasound is a viable, minimally invasive method for assessing costal relative diaphragmatic blood flow that could be used in clinical settings. Our pulmonary vascular content area is next. The definition of pulmonary hypertension has evolved to include those with a resting mean pulmonary artery pressure of 21 to 24 millimeters mercury. In this issue, Cololillo and colleagues report on the evaluation of patients with systemic sclerosis from the European Scleroderma Trials and Research Database, all of whom had an available pulmonary hypertension screening echocardiogram and pulmonary function test parameters. To determine the diagnostic performance of echocardiogram and PFT screening parameters in detecting patients with systemic sclerosis with a mean pulmonary artery pressure of 21 to 24 millimeters mercury at a right heart catheterization. Tricuspid annular plane systolic excursion, or TAPSE, over systolic pulmonary artery pressure was lower in the group of patients with the mean pressure of 21 to 24 than in the non-pulmonary hypertension group. The TAPSE to SPAP ratio, less than 0.55 millimeters per millimeter of mercury, had the highest specificity at 79%, positive predictive value at 50%, and accuracy at 68%, with a sensitivity of 45% and negative predictive value of 75%. There was no difference in the other echo parameters. A diffusing capacity less than 80% predicted had the highest sensitivity at 89% and negative predictive value at 80%, but the lowest specificity, 18%, and positive predictive value, 31%. These findings identify diffusing capacity less than 80% of predicted as the most sensitive screening parameter, and a TAPSE over SPAP of less than 0.55 as the most accurate overall predictor of a mean pulmonary artery pressure of 21 to 24 millimeters of mercury in those with systemic sclerosis, potentially useful parameters in determining who should be evaluated with a right heart catheterization. On to our sleep medicine content area. The healthy behavior effect is a potential source of bias in observational studies evaluating the association of positive airway pressure adherence with health outcomes in obstructive sleep apnea. In this issue, Lanois and colleagues linked data from the IRSR Pays de la Loire sleep cohort to proxies of healthy behaviors in health administrative data in order to determine if adherence to PAP is associated with healthy behaviors and healthcare resource use prior to device prescription. 2,836 patients, 65% of whom were PAP adherent, were included. Being adherent to cardiovascular active drugs and being a person who does not smoke were associated with a higher likelihood of PAP adherence. Patients with no history of drowsiness-related road accidents were more likely to continue PAP. Those who were PAP adherent used less healthcare resources 2 years prior to PAP initiation. These results show that patients who adhere to PAP therapy for obstructive sleep apnea are more adherent with other health interventions and use less healthcare resources prior to PAP initiation. This association should be considered when interpreting the association of PAP adherence with health outcomes. Completing this section is a chest review on sleep apnea and stroke. Next is our thoracic oncology content area. The clinical and economic implications of different recurrent malignant pleural effusion treatment pathways have not been fully evaluated. In this issue, Aust and colleagues report findings from a retrospective cohort study of 3,090 patients with rapidly recurrent malignant pleural effusions from SEER Medicare, designed to assess the clinical outcomes, complications, healthcare resource use, and costs associated with various rapidly recurrent malignant pleural effusion treatment pathways. The second pleural procedure included thoracentesis 62% of the time, chest tube 17%, an indwelling pleural catheter 13%, and thoracoscopy 7% of the time. A third pleural procedure was required more often if the second procedure was thoracentesis, and the mean number of subsequent pleural procedures was lowest after thoracoscopy. Average total costs after the second pleural procedure were lower for the indwelling pleural catheter or chest tube compared to thoracentesis and thoracoscopy. These findings suggest that early definitive treatment of a rapidly recurrent malignant pleural effusion is associated with fewer subsequent procedures and lower costs. Also in this section is a research letter that evaluated the impact of structured reporting for lung cancer screening low-dose CT scan incidental findings on physician management, and a special feature article that summarizes the proposed 9th edition TNM classification of lung cancer. I encourage you to read our Humanities and Chest Medicine section, where you'll find an exhalations piece titled My Voice, and our commentary series, where you'll find a piece describing a systems-based approach for addressing the workforce crisis in intensive care. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the October issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.